Additionally, in our budget, we proposed increases for the Centers for Disease Control's Division of Adolescent and School Health, or DASH. And part of the reason we did that is they fund comprehensive sex ed in schools as well. So we think that HIV prevention for young people is important. It must be evidence-based and accurate. It's important to do it in school settings, but it's also important to do it in other settings as well. Thank you.
Mr. Crowley, I heard stories that ex-President George W. Bush did a little more for the AIDS sufferers in Africa than our present administration, and I'm sort of wondering if that's correct or why it is, and if you plan to do more.
You are correct that some global advocates are concerned with where we're going and have been advocating for increased funding for global AIDS. I would say that President Obama is committed to continuing PEPFAR, and he's committed to leading on improving global health. Earlier this year, we proposed a broader global health initiative, and as I said, we believe it builds on the success of PEPFAR. Once this program is fully implemented, 70% of the funding that's available through this initiative will still be for PEPFAR and global AIDS, but it's broadening the base, saying if you're looking at sub-Saharan Africa, for example, people there die not only of HIV/AIDS, they also die of malaria and TB and other tropical diseases, and we must build on the success of PEPFAR to do that. And I think there's a tension that people think that we're walking away from our commitments to PEPFAR. I think we would disagree. I think in the budget that we put out, we promised a commitment that I believe, I could be getting this number wrong, of $51 billion for the PEPFAR program over the next 6 years. So I think that that's a very significant financial commitment, and it'd just be wrong to say that we're backing away from leading on global AIDS issues. But I do acknowledge that some advocates would like us to do more. They'd like us to scale up treatment faster, and there's always a healthy tension there. Thank you.
Good afternoon. My name is Mike Schenemeyer. I'm with the United Church of Christ HIV and AIDS Network, and I'm interested to have you reflect a little bit more on the involvement of faith and the role of faith in this work, how you're engaging with them. For example, have you or will you convene a group of faith leaders at the White House as you're putting together this national strategy? And how are you going to work to access what faith can bring to this?
Thank you. I've already met with numerous faith leaders. You know, we have within the Domestic Policy Council, I mentioned, my role for health and AIDS and education. We also have the Office of Faith-Based and Neighborhood Partnerships that's led by Josh Dubois. We work very closely together. We've met with different clergy groups. Probably the biggest one was MBLACA, the National Black Leadership Commission on AIDS, excuse me. But you're right, we need to do more. One of the things that's been surprising as we've traveled the country for these community discussions is a hunger for people to have us engage more broadly with the faith community. I think sometimes in the HIV community there's some perception that we just need to manage those faith leaders and sort of keep them at a distance. But a lot of places we went, they're saying, no, we need more. We need more engagement. And I think that's an important part of what we do.
Mr. Crowley, this question is not directly related to AIDS, but it is in the general health area. A number of cities throughout the country have made available for free, in most cases, needles that can be used, syringes that can be used by people who have various communicable diseases in an effort to try to cut down the diseases that are perhaps venereal diseases or whatever. Would you be in favor of a national policy that made available needles at no charge at all to addicts?
There's sort of two elements to respond to your question. Is do we support access to clean needles and free of charge? I mean, I don't think we've ever taken a position on when people can be paid for. I mean, in most contexts, we're not talking about programs where you're charging people, but we haven't sort of dealt with the cost of that. But what I can say about this issue around needle exchange programs is that the President said he supports needle exchange programs when they're part of comprehensive programs to treat drug addiction and prevent HIV and other diseases. So as long as they're part of evidence-based programs, that he thinks they have an important role to play. Thank you.
Hi, Mr. Crowley. I'm a long-term survivor of AIDS, and I started taking AZT when it first came on the market, and now it's generic. That's how long I've been taking it. I'm hoping that a national HIV policy will deal a little more realistically with long-term survivors. What I constantly hear from medical professionals is that AIDS is a chronic manageable disease like diabetes, and I'm wondering if they missed the day in school on diabetes, which is a horrible disease and at pandemic levels in this country. The long-term survivors in this country are pretty much a national treasure. There's not many of us left, and we face special challenges because of our long-term use of these medications and the debilitating effects on our bodies.
Right. You raise important questions, and some of this has come up in the context of aging and HIV, and I know that one part of this answer won't deal with what you said, but part of it will. I think that we've been sensitized as we've been in these community discussions, the fact that we need to deal with an aging population, and HIV prevention isn't just about young people. Older Americans get HIV and are at risk for HIV, so we need to deal with that, which we haven't. But just the point you raised, that people are living longer, we don't fully understand all the metabolic changes, and we haven't fully come to grips with that. And I think over time, you're right, we are going to have to shift some of our focus to just understanding some of these better. Some of the drugs now, we have later generations we think have lower toxicity than some of the earlier drugs. But we also know we need to continue doing research both to study what's going on, but to find even safer, more tolerable drugs. So I think you raise important issues.
My name is Maya Jones, and I'm a senior at Cleveland School of the Arts, and I've been privileged to have a comprehensive sex education program for 4 or 5 years now. And it seems that we have one of the only K through 12 comprehensive sex programs in the nation, and I wanted to know if your office was going to support more programs everywhere, more than just, where they already are. Because
since I've been here today, I've learned about this program from many people, and so I know there's lots of community members that are proud of this. What I can say is that the present, I mentioned this move to funding from abstinence only to comprehensive evidence-based programs. That's something we strongly support. We think we need to do more at DASH, which really funds comprehensive sex education in schools, and I think that you'll see more opportunities for that. I haven't learned enough about or even thought about your specific program to say it's a model for the nation, but I think since so many people have said they think it's a great success, I think it warrants us taking a look at to see what lessons it holds for other places as well. Thank you.
Hi, my name is Sonica Jones, and I'm with the AIDS Task Force of Greater Cleveland. And my question is, you say that the Ryan White funding is only for 4 more years. Why isn't it implemented for longer? I mean, if you all are writing bills and doing that type of thing, why couldn't you all extend it a little longer than 4 years?
Well, that doesn't mean we think that the program should go away after 4 years. That programs are reauthorized for a specific length of time. Some people in the HIV community wanted the program reauthorized for a shorter period of time. There's a broad community consensus that called for the program to be reauthorized for 3 years. We ultimately came out at 4 years, in part because I raised questions about the feasibility, about having the kind of dialogue we need about reauthorizing this program in an election year, just feeling like it would lend itself too easily to just having an unhealthy political discussion, so we felt that 4 years made sense. We also know we're engaged in a conversation now about health reform, and that could change dramatically what we need from Ryan White. Ryan White exists to fill in gaps left by the rest of our health system. So if we're going to expand insurance elsewhere, we'll still need Ryan White, but we might need a very different program. Now, some people said, well, we need to reauthorize it for only a year because we need to quickly adapt this program. But I think a year would be too short. When we get a health reform law signed, we're all going to be busy implementing it. So the judgment was like 4 years is best, and we'll have to see then how not do we need a Ryan White program, but how do we need to adapt it to make sure that it's being as effective as possible. But again, I think that people should understand that I don't have a vote in Congress, but at least from my perspective, we're going to have an ongoing need for a Ryan White program even longer than 4 years.